Hi everybody, this is Shannon McCall. I'm a gastrointestinal pathologist in the Department of Pathology at Duke University Medical Center. And today I'm going to talk to you about this slide, which is a stomach ulcer. The first thing we want to do when we take a look at this slide is review where we are. We're in the GI tract. There are 4 layers in the GI tract, particularly in the stomach. Let's go over them here in this more preserved area. We have the mucosa, which is composed of 3 parts. We have the epithelial cells, the lamina propria, and the lower boundary is the muscularis mucosa. That's this wispy muscle layer right here. Beneath the mucosa, we have submucosal tissue. And the 3rd layer is the muscularis propria. That's the 2 muscle layers of the GI tract. And beneath that, we have subserosal connective tissue, which is a little bit of adipose tissue, some blood vessels. And bounding that, we have a single mesothelial cell layer called the serosa. So we have 4 layers of the GI tract. Both on this side, they're preserved, as well as on this side, they are preserved. And in the center of this slide, we notice that the 4 layers of the GI tract are disrupted. This is a crater-like lesion. It is an ulceration where we have lost the epithelium and developed this crater. So what could this be? What's going on with this particular slide? So we need to get some clues. One of the first things we can do is go to higher power on the more preserved areas. So let's see, here we have the boundary between the ulceration and the more preserved areas, and we'll get a little bit of a clue here. We've got some lymphoid aggregates. See these purple aggregates of cells? These are lymphocytes, and they're in little collections. And then we could go to even higher power and look in the lamina propria. Near these collections of lymphocytes, we see abundant chronic inflammation. This is plasma cells mostly. You'll remember from histology that plasma cells have eccentrically placed nuclei and abundant kind of pinkish cytoplasm. There are also lymphocytes mixed in here in the lamina propria. And then as we move over and we approach the area of ulceration, we start to pick up some acute inflammation as well. And the acute inflammation is characterized by neutrophils. So let's find that area, and I will show that to you. Here we go. So at the boundary, closer to this ulceration, we can see we've picked up these polymorphonuclear leukocytes, which are the polys that have multiple lobes of their nucleus. They kind of look like pepper. So in this area of ulceration, we have a mixture of these neutrophils and this bright pink fibrin debris. That's ulcer exudate. And then in the glands near the ulceration and in the lamina propria, we can start to pick up a few polys as well. So what is our differential diagnosis for this ulceration? Well, in human beings, the common causes of ulceration in the stomach are H. pylori or Helicobacter pylori associated ulceration, and also chemical associated ulceration. Some of the chemicals that patients commonly attribute their ulcers to would be NSAIDs, also alcohol, and other chemicals. Anytime, basically, that you have a disruption in the balance between protective forces of the stomach and destructive acidic or chemical forces, you can get this kind of stomach ulceration. So those are the 2 common causes. Less common causes would be tumors can in fact ulcerate the stomach, and also viruses can ulcerate the stomach, particularly in immunocompromised patients. You would want to be sure to look down in this ulcer exudate. You see these small blood vessels. You'd want to make sure that there is no cytomegalovirus inclusions in these small endothelial cells, which there are not here. But again, that would be an uncommon cause and mostly for immunocompromised patients, patients on chemo, patients with HIV, etc. And then also, since we're down here, I can prove to you that there's no tumor here. There's no malignant appearing glands here as well. So most likely this patient's ulcer is caused by one of the common causes is either going to be H. pylori or chemicals. I can tell you that these lymphoid aggregates are suggestive of H. pylori. They're not pathognomonic. We'd actually want to see the organism to diagnose the H. pylori, so we can sometimes look for them on H&E. And the H. pylori organisms typically live just on top of the epithelial cells here. If you look for a gland, inside a gland, maybe here is one, they typically look like little seagull-shaped organisms, and they live in the mucin just on top of the epithelium. And the diagnostic thing would really be to get an immunohistochemical stain specific for this organism, which would turn the background of this slide blue and would light the H. pylori organisms up brown. And in fact, if we did an H. pylori stain on this patient, I'm sure we would highlight some of these little bugs, and we would get the diagnosis of H. pylori associated gastric ulcer in this patient. So thanks for your time. This is Shannon McCall from Duke University Medical Center. Thanks, bye.